A 73-year-old retired teacher comes to see me. Her blood pressure has been beautifully controlled for 2 years. Her readings are consistently around 118 over 62. Her previous doctor called it textbook, but for the past 8 months, she has been exhausted by noon. She feels unsteady when she gets up from her prayer mat. She has stopped taking her evening walks because something just feels off and she cannot explain what. 3 different doctors told her it was probably her age. It was not her age. It was a blood pressure target that was set for a clinical trial population that looked almost nothing like her, in a diastolic number that had been quietly pushed so low that her heart muscle was not receiving adequate blood supply between beats. Within 6 weeks of adjusting her treatment, she was walking again. Her story is not unusual, and the reason it keeps happening has everything to do with a number most patients have never been told to pay attention to, and a target that most doctors have never had the time to fully explain. I am Dr. Hameed Ullah Shaheen, and today I want to give you the blood pressure conversation that a 15-minute appointment almost never has time for. Not because your doctor does not care, but because the full picture, what the research actually says about blood pressure targets in adults over 65, what the risks of overtreatment look like, and what you should specifically be monitoring that most patients never do, requires more time and more depth than most clinical visits allow. By the end of this video, you will understand your blood pressure numbers in a fundamentally different way. You will know what questions to ask at your next appointment, and you will have a simple home protocol that gives you more clinically useful information than any single reading taken in a doctor's office. Let us begin with the biology, because everything else follows from it. When you are young, your arteries behave like new rubber tubing. They are elastic, flexible, and forgiving. When your heart contracts and pushes blood out, those arterial walls expand slightly to absorb the force, then recoil to maintain pressure between beats. The result is a smooth, buffered flow of blood throughout the body. As the decades pass, that elasticity diminishes. Arterial walls stiffen. The elastin fibers that provided flexibility gradually break down. Calcium deposits accumulate within the vessel walls. What was once flexible tubing becomes something closer to rigid pipe. This process, called arteriosclerosis, distinct from the plaque building of atherosclerosis, is not a disease in the traditional sense. It is a near universal feature of cardiovascular aging, and it has a direct, predictable effect on your blood pressure readings. When the heart contracts against stiff arteries, the pressure spike is higher and sharper because there is no elastic give to absorb it. So the top number, the systolic, climbs. Meanwhile, the bottom number, the diastolic, may stay normal or drift lower because stiff arteries also lose some of their capacity to sustain pressure during the resting phase between beats. The result is a pattern called isolated systolic hypertension, elevated top number, normal or low bottom number, and it is not a variant form of hypertension in older adults. It is the dominant form. It is what the majority of seniors over 65 are actually managing. Here is why this matters profoundly for treatment. The guidelines that set blood pressure targets were built substantially on research conducted in mixed-age populations, with significant representation of middle-aged adults whose arterial physiology is fundamentally different from that of a 72-year-old. When those targets are applied without adjustment to an older adult with stiff arteries and a different physiological baseline, the risk-benefit calculation changes, sometimes significantly. That is not a fringe position. It is the conclusion of a growing body of geriatric cardiovascular research. And it is the gap between what the guidelines say and what individualized care for older adults actually requires. What the landmark research really said and what got left out. In 2015, a major federally funded study called the SPRINT trial published results that significantly influenced blood pressure guidelines worldwide. The study enrolled over 9,000 adults at elevated cardiovascular risk and asked a straightforward question: Does pushing the systolic blood pressure below 120 produce better outcomes than managing it to the standard target below 140? The primary finding was striking. The intensively treated group had fewer major cardiovascular events, fewer heart attacks, less heart failure. The results were compelling enough that the trial was stopped early, and within a relatively short period, major cardiology organizations lowered their recommended blood pressure targets for most adults, bringing the number that millions of patients are now chasing to below 130/80. What did not receive equivalent attention was the other side of the data. The intensively treated group, the one pushed below 120, also experienced significantly higher rates of serious adverse events. Acute kidney injury was substantially more common. Dangerous drops in blood sodium and potassium were elevated. Falls requiring medical attention occurred more frequently. Sudden loss of consciousness happened more often. And when researchers specifically examined the older, more physically vulnerable participants within the study, the subgroup most representative of the patients receiving these guidelines, the balance between cardiovascular benefit and serious harm looked meaningfully less favorable than it did in younger, healthier participants. The researchers themselves flagged this. Geriatric medicine specialists have been raising it consistently since the trial was published. The SPRINT results, they have argued, should not be applied uniformly across all adult populations and should be interpreted with particular caution in older patients where the treatment trade-off is fundamentally different. That nuance was present in the data. It did not make it into most clinical conversations. What made it into clinical conversations was the number. Get below 130. And millions of seniors are now living inside that target. Some of them experiencing exactly the adverse effects the data predicted, with no one connecting those symptoms to the medication on their kitchen counter every morning. And why I want to talk about the diastolic number, the bottom figure in your blood pressure reading, because it is the most underappreciated and most clinically consequential number for adults over 65, and it receives almost no attention in standard blood pressure conversations. Here's the physiology you need to understand. Between heartbeats, the phase the diastolic number measures, the heart muscle itself is being resupplied with oxygen-rich blood through the coronary arteries. This is when coronary filling predominantly occurs. The heart, while it rests and refills, is simultaneously being replenished. If diastolic pressure drops too low, that replenishment is compromised. In a younger adult with open, flexible coronary arteries, this may cause no perceptible problem. In an adult over 65, the majority of whom carry some degree of coronary artery narrowing or calcification, whether or not they have been formally diagnosed, a chronically low diastolic is not an abstract concern. It may represent a quiet, ongoing oxygen deficit to the heart muscle with every single cycle. Multiple large studies have documented what cardiologists call the J-curve phenomenon. When researchers plot blood pressure against cardiovascular outcomes across large populations, they expect a straight line. Higher pressure, worse outcomes. And they do see that across the upper range. But as blood pressure is pushed below a certain threshold, outcomes do not keep improving. Risk begins to rise again. The graph curves upward at the low end, tracing the shape of the letter J. The most consistent and clinically significant expression of this J-curve in older adults involves the diastolic number. Research published in major cardiovascular journals has documented meaningfully elevated risk of cardiovascular events, cognitive decline, and organ injury in elderly hypertensive patients when diastolic pressure falls below approximately 60 to 65 millimeters of mercury. A diastolic of 58 or 55 on a home monitor is not just a number to note. In an older adult already managing cardiovascular risk, it may warrant an urgent conversation about whether the current treatment intensity is appropriate. Ask yourself right now, do you know what your diastolic number has been averaging over the past 3 months? Most patients on blood pressure medication can tell me they're systolic. Very few can tell me they're diastolic. That imbalance reflects exactly where the clinical conversation has been focused and where it needs to shift. The reading your doctor's office is not taking. There is a blood pressure measurement that is almost never taken at a standard clinical appointment, and it may be the most important one for adults over 65. It is a standing blood pressure measurement. The reading your doctor takes at every visit, seated, after 5 minutes of rest in a quiet clinic room, captures one slice of your blood pressure profile under highly controlled conditions. It tells you what your pressure does when you are still, seated, and calm. It tells you almost nothing about what your circulation does the moment you stand up and walk to the bathroom at 6 in the morning. In younger adults, the body's baroreflex, the automatic system that detects and corrects blood pressure changes within seconds, responds quickly enough that the shift from seated to standing produces, at most, a brief sensation of lightheadedness that passes within a moment. In adults over 65, the baroreflex response slows. Blood vessels are less responsive. The autonomic nervous system, which coordinates the rapid compensatory tightening of vessels when you stand, operates with reduced precision. And blood pressure medications that lower resting pressure make every one of those compensatory mechanisms work harder, meaning the drop that occurs when you stand becomes larger, more pronounced, and more sustained. The clinical term is orthostatic hypotension. It is defined as a drop of at least 20 points in systolic pressure or 10 points in diastolic within 3 minutes of standing. And it is one of the most under-recognized, under-discussed, and under-tested blood pressure dangers in older adults. Its consequences are not abstract. A patient who feels dizzy every morning when getting out of bed, who holds the wall when standing up from prayer, who has become slightly unsteady navigating stairs. That patient may not be experiencing age. They may be experiencing a medication-driven pressure drop that their clinical readings have never captured because the measurement was never taken in the right position. Hip fractures in adults over 70 carry mortality risks that rival many cancers. A medication-induced fall is not a minor side effect. For a patient living independently, it can be the beginning of a cascade that ends that independence. I want you to do something right now, or as soon as you finish this video. Take your blood pressure monitor. Sit quietly for 5 minutes and take a reading. Write it down. Then stand up, wait 2 full minutes, and take a second reading standing. Write both numbers down. If your systolic drops more than 20 points between those 2 readings, that information belongs in front of your doctor. Specifically, with the words, "I would like to be evaluated for orthostatic hypotension, and I would like a standing blood pressure measurement at my next appointment." That one test can reveal a medication-driven problem that years of seated clinical readings have never caught. What the 65 video has been building toward. What should the target actually be? I will give you an honest answer. And the honest answer begins with acknowledging that there is no single correct number for every adult over 65. Anyone who hands you one universal target without considering your age, your functional status, your fall risk, your kidney function, and your specific constellation of medications is giving you a simplified answer to a genuinely complex question. What the current evidence does support, across multiple studies and increasingly endorsed by geriatric medicine specialists, is a more stratified approach. For adults between 65 and 75 who are in good functional health, without significant frailty or fall risk, a systolic target in the range of 130 to 140 is generally appropriate, provided the diastolic is not being pushed below 65 in the process, and provided orthostatic drops are being actively monitored. For adults over 75, and particularly for those managing multiple conditions, carrying any degree of frailty, experiencing cognitive concerns, or at elevated fall risk, a systolic target of 140 to 150 is increasingly supported in the geriatric medicine literature as the appropriate individualized goal. This is not relaxed medicine. This is precise medicine. The question in this group is not whether lower is theoretically better. The question is whether the specific risks of aggressive treatment in this specific patient, falls, kidney strain, coronary underperfusion, cognitive effects, outweigh the cardiovascular benefits. And that is a calculation that requires knowing the individual, not just the guideline. For every adult over 65 on blood pressure medication, 2 questions should be part of every medication review, and almost never are. What is the diastolic number running? And what happens to the blood pressure when the patient stands up? Let me give you something concrete before this video ends. This week, purchase a validated upper arm blood pressure monitor if you do not have one. Wrist monitors are less reliable for clinical decision-making. Upper arm, validated, with a cuff that fits properly. Starting tomorrow, take readings twice daily, once in the morning before medication, once in the evening. Sit quietly for 5 minutes first. Take 2 readings and record the average. Do this every day for 2 weeks. Also starting tomorrow, perform the standing test I described. Seated reading first. Stand up. Wait 2 minutes. Standing reading. Record both. Do this every morning for 2 weeks. At your next appointment, bring your log. Then ask your doctor 2 specific questions. First, what systolic target are you using for me, and was that target chosen with my age and fall risk specifically in mind? Second, has my medication ever been evaluated for its effect on my standing blood pressure, not just my seated reading? If your diastolic has been averaging below 65, say that explicitly. My diastolic has been running consistently below 65. I would like to discuss whether this is appropriate given my age and the J-curve research in older adults. If you experience any dizziness, unsteadiness, or lightheadedness when rising, from a chair, from the floor after prayer, from bed in the morning, say this: I would like to be formally evaluated for orthostatic hypotension. These are not confrontational questions. They are the right questions. They are the questions that turn a prescription renewal into an actual clinical conversation about your actual physiology. The retired teacher I described at the beginning of this video spent 8 months feeling like her body was slowly withdrawing from life. She had stopped walking. She had started avoiding activities she loved. She had been told by multiple doctors that it was probably age. It was a diastolic of 61 and an orthostatic drop of 24 points every time she stood up. 6 weeks after her treatment was adjusted to reflect her actual physiology rather than a population-level guideline, she was walking again. I am not telling you that your medication is wrong. I am telling you that the conversation about your medication, what it is targeting, what it is doing to your diastolic, and what it is doing to your blood pressure when you stand up, may not have happened yet in the way it needs to. You now have the vocabulary, the questions, and the protocol to make that conversation happen. Share this video with someone in your family who manages their blood pressure every morning, who checks that number faithfully, but may never have been told about the bottom figure, the standing measurement, or the J-curve. That person deserves this information. Leave a comment below. Tell me, what has your diastolic been running? Or tell me if something in this video made you realize a conversation with your doctor has been overdue. I read every comment. I am Dr. Hameed Ullah Shaheen. Manage your blood pressure with understanding, not just obedience.